How's it going, everybody? So in this video, I wanted to talk a lot about heart disease, LDL cholesterol as a causal risk factor, and how nutrition and dietary practices play a role in all of that. So really, more specifically, I want to talk about the science behind LDL as a causal risk factor, and really what people who advocate LDL as a causal risk factor, what the science that they're using actually says. Okay, so this might actually rustle some jimmies of a lot of my long-term high-fat diet or low-carb dieter type subscribers. Please note that I am not advocating any one position. I'm simply discussing the evidence of, I guess, the opposing view. So don't get the idea that I believe any of this evidence. I'm simply discussing the evidence that these other people go based on, okay? So, and this is going to be far different than the normal discussion we have about LDL. We're actually going to talk about the actual evidence that they use rather than just why it might not be sufficient or whatever. So let's just get into it. Okay, so you will always, you guys are probably used to this already, you guys and you girls. So, experts like Barbell Medicine, maybe even Lane Norton, obviously all the vegan camps, Joel Furman, Neil Bernard, Michael Greger. I mean, obviously all of the plant-based gurus. Then we have the guys at Sigma Nutrition, and who else? I mean, there's pretty much anyone who considers himself evidence-based that are not in the low-carb group typically will tell you that the evidence is clear that LDL is a causal risk factor for heart disease. So I have spent the last couple months really diving into the research behind this, because everybody is so they speak in absolutes and they're very convinced that it's established now, okay, that the weight of the evidence is heavy on that side. So let's talk about that evidence. All right, so the main premise that is basically it's not LDL being elevated in the short term. So we have people like what cholesterol code, what's his name? He's an engineer or whatever. Damn it, what's his name? I can't. He's like a computer programmer, but he has a website where he does these experiments with people where they show transiently your cholesterol levels basically fluctuate throughout the day and from day to day. Okay, and he's a low carb guy. Can't believe I forgot his name. But the problem is, so people will be like, oh, well, in the short term, your LDL cholesterol rises and falls, and a lot of it doesn't even have to do with your diet. It could be the time of the day, maybe you just woke up. It could be, if you fast for a certain amount of time, if you lose a lot of weight, LDL levels will rise in response. But basically the main premise behind these, cholesterol model people, LDL cholesterol, saturated fat, is the devil type people. It's not the short-term rise in LDL that they believe is a problem, but more so high LDL over the long term seems to cause kind of a wear and tear effect on the arteries over time. This could be due to just with the total higher amount of LDL cholesterol, there's more oxidized cholesterol as a result, and also, according to these people, it's the deposits of these fatty acid substrates in the arterial wall over time that can create plaques, and then plaques can create blockages, and what really leads to the crisis event of a heart attack is the plaque breaking off, causing a blood clot or whatever. So it's not the LDL cholesterol in the short term, but more so over the long term that these people believe is a problem, okay? And they use meta-analysis, cohort studies, population studies to back this up. Now, as far as they're concerned, the magnitude of effect seems to be high enough to suggest that this is a significant correlation, okay? And we have to understand pretty much anything in nutrition science, you're not going to be able to establish a good picture, a good understanding of what's actually going on based on one piece of evidence, okay? Pretty much you have to combine a multitude of different types of studies with different magnitudes of effect in various scenarios and combine them together to create an accurate picture. Which is why I personally don't like the idea of like being so convinced that anything is, actually verified or proven or whatever, because it's just how convincing is the evidence combined together. So anyway, like unless you can do like 100-year butter intervention trial where people just eat sticks of butter every day for an entire lifespan, and then we see who has the most heart disease. That is unrealistic and never going to happen, but it would be nice. Although there is a lot of low-carb gurus or high-fat gurus that have lived the whole lifespan and have died, and we can look at them and see, well, what did they die of, and what is the percentage, especially compared to the low-fat group, and this and that. And so I'm going to be honest, I looked at the history of low-carb gurus, which, by the way, I've been following a high-fat, low-carb diet for years now, and I still do to this day. But I have to admit, with a few exceptions, there's a high percentage of these people do die of heart-related conditions, which is interesting. Again, I'm not like suggesting that it's the low-carb diet or saturated fat that caused their deaths. I'm just saying that's something I noticed. And that, to me, is the closest thing that we can get to, long-term intervention trials, to look at people who willingly and freely, voluntarily followed the certain diet pattern over the long term, and then we just see, well, what happened. It's kind of like looking at biographies, basically. But with all forms of evidence, there are confounding variables. So anyway, so there's meta-analysis, and basically they just show LDL over the lifespan seems to be the prevailing factor, and there seems to be a very clear link. So, furthermore, to establish a causal link, here's what they do. So there's studies done on genetics, people with genetically high LDL cholesterol from the beginning of birth till death, and people with genetically low LDL cholesterol from birth and then death, okay? And what they find is people who have genetically high LDL cholesterol at birth, just a genetic polymorphism that makes their LDL cholesterol high over their lifespan, they have greater incidences of heart disease or of heart attacks over their lifespan compared to people who have genetically low LDL cholesterol. They have a lower incidence of heart disease risk or of heart attacks over their lifespan. So there seems to be a strong correlation between LDL levels and heart disease when we're talking about these genetic studies, okay? And I have rebuttals to this, but this is pretty strong evidence, I must admit, and I can understand why people might use this as part of their evidence for why it's convincing. So again, groups of, large groups of people who have genetically high LDL cholesterol. Their LDL cholesterol is extremely high just based on genetics. Have more heart disease or heart attacks. People who have genetically low LDL cholesterol have low incidence of heart attacks, okay? So that's the first line of evidence, okay? And then the next thing that they use are intervention trials and cohort studies on people who have pre-existing heart conditions who use statin drugs. Okay, and they find and to me, from what I've seen, the magnitude of effect is relatively low. But basically you see a lower risk of further heart attacks when you take statin drugs. So the magnitude of effect of the statin drug interventions are going to depend on the person who is interpreting those studies. From what I've seen, generally speaking, the relative risk. So basically, we're already working with populations of people who already have had pre-existing heart disease. Okay, so already that's like a confounding variable. Okay, that does not replicate the regular population who's eating, who has low LDL based on diet or high LDL based on diet. And they don't have pre-existing heart disease. It's not the same as somebody has pre-existing heart disease and they're artificially lowering their LDL cholesterol using drugs. That's the first thing. The second thing is the magnitude effect from what I've seen is something like people who take statin drugs with heart disease, 2 out of 4 people who take statin drugs, 2 out of 4 people have heart attacks now who take statin drugs. Compared to the groups that don't take statin drugs, it's like 3 out of 4 have the further heart disease risk. So the magnitude of effect is kind of iffy on those studies. And also there's evidence that they may have less risk of further heart disease in the future, or heart attacks in the future, less risk with the statin drugs. But they have a significant increase in risk of all-cause mortality or of other issues that may be related to the statin drugs, okay? So that's kind of like the weird kind of working, that's the evidence that they're working with there. Now, it goes even further, okay? So there's a couple of other things they have. Studies on rats where they show a direct increase in heart disease incidence or heart attack incidence with saturated fat feeding or what have you. But, that's rats, And obviously they have, studies done on rabbits where there's a direct increase in heart attacks with feeding saturated fat. But they're fucking rabbits. So, that to me, that's just... You shouldn't listen to that guru if they're trying to equate that to humans. And that's kind of like Caldwell-Esselstyn and, or not Caldwell-Esselstyn, who was it? Is it Colin Campbell in the China study? I have the book, I read it, in the actual study, and his studies done on rats where they fed him a carcinogen and then fed him casein protein versus pea protein. Yeah, that's not a good working evidence to use with to extrapolate to humans. But so there's that. So we have the feeding studies on rats. We have the intervention trials with statin drugs, and then we have the genetic studies that showed people with genetically high cholesterol or high LDL have greater heart disease. People with genetically low cholesterol, low LDL have less heart disease. So 2 forms of LDL rising in heart disease and LDL lowering and less heart disease. Okay. So the next part of this is, and by the way, the genetic studies show the heart disease correlation regardless of whether they smoke or have diabetes, okay? Their definition of diabetes, which is probably more like hemoglobin A1C rather than measuring fasting insulin, but it is what it is. So regardless of other risk factors present, those genetic studies still show that correlation. So the next part of this is HDL cholesterol. So this is actually fascinating to me. Okay. So, one of my rebuttals to all of this is, well, how do we know that these people who have genetically high LDL cholesterol, who also have more heart disease incidence, how do we know that there's not a lurking variable, as my client who's a professor of data analysis tells me it's called, lurking variable? How do we know there's not a lurking variable, right? Meaning what if, so sure, the LDL cholesterol is high and, it's genetic. But what if there's something that comes before that genetically high LDL cholesterol? What if there is, their LDL cholesterol is high because of an underlying pathology that's genetic, right? And that underlying pathology might be what's causing the damage. And it might not actually be the LDL cholesterol itself. And a reason why I wonder this, because I understand that the LDL particles themselves in the blood, they're responsible for so much more than just depositing, than just creating plaque. They have a purpose of transferring nutrients and energy throughout the body. And they play a vital role in fat metabolism. And there's a wide variety of nutritional factors and also disease factors and things that can influence LDL cholesterol. Again, fasting, weight loss, the types of fats you're eating, the types of carbohydrates you're eating, whether you're in a caloric surplus, whether you're low in carbs, certain viral infections. So what I'm getting at here is like the LDL being high, regardless of how significant the magnitude of effect of that correlation may be, what if there's a lurking variable before that? Now, as a medical practitioner, you have to have solid, hard, fast rules because you don't have time to wait for the evidence, and you can't, questioning all these things is important for the evolution of science. But when we have patients that are dying of a disease or are at risk of dying, we can't just be like, oh, well, we don't really know, it's not certain, blah, blah, blah. There's not a lot of room for ambiguity. So you've got to have hard and fast rules so that you can guide your patients towards improving health outcomes with the best evidence available. So I don't really see doctors as like being shills and stuff like that if they follow that evidence. But I do think speaking in absolute terms is a disservice, and it keeps people dogmatic from furthering their understanding of what might actually be going on. It's possible that, maybe saturated fat is killing people. Maybe it is. Maybe it is the LDL. It's a causal link, and we should reduce LDL at all costs. But maybe there's a lurking variable. So that brings us to HDL cholesterol. So I think HDL cholesterol is very interesting in this discussion. So while LDL cholesterol, using drugs, manipulating the LDL levels with drugs, seems to change our risk of heart disease, our genetic polymorphisms that influence LDL cholesterol seems to have a direct relationship with heart attack incidence. HDL doesn't have that same correlation. So when you look at people who have genetically high HDL cholesterol, they don't seem to have that same protective benefit. They don't seem to have that same like high HDL, when we look at people's like blood markers, tends to be a proxy for health rather than a causal risk factor. People who have genetically high HDL don't have lower risk of heart disease. People who have genetically low HDL don't have a higher risk or a lower risk, a higher risk of heart disease. Okay, because the typical narrative is, well, HDL seems to be preventative, right? It seems to be protective. So if you have a higher HDL level, then the LDL level doesn't matter. Like I posted data from Framingham that showed this. But genetically high HDL doesn't protect you. And genetically low HDL doesn't make you more susceptible to heart disease. So that genetic relationship is not there with HDL, but it's there with LDL. The second thing is drug companies have tried making drugs for HDL cholesterol based on this idea that HDL cholesterol could be protective. So they tried making drugs that increase HDL with an attempt to improve health outcomes and reduce risk of further heart attacks. And what you find with these drugs is that they don't seem to have the same protective benefit. So increasing HDL through drugs don't seem to protect people from heart disease. Having high HDL genetically doesn't seem to protect people from heart disease. While the evidence, you can argue the magnitude of effect and confounding variables, we do see a relationship with drugs on LDL and with genetics on LDL. So this is kind of like where the physicians and the scientists and people who advocate the LDL as a causal risk factor model of heart disease risk, they draw the line. And where they say, well, this is how we perceive LDL is a causal risk factor, because we see in practice, they're like, well, if LDL is just a correlation and it doesn't actually have a causal link, then why do we see it with these other things, right? If it was just a correlation, then HDL cholesterol, maybe we'd see a similar pattern that we do with LDL, with the genetic studies and with the drug studies. And, because we see the correlation with HDL, right? Just like we see the correlation with LDL. But with HDL, when we actually put it into practice, and again, remember, with nutrition science, it's very hard to design studies, especially ethical studies, so don't put people at unnecessary risk of dying from the disease being studied. It's very hard to do the right intervention trials to actually show causation. But with the studies we do have, it's very unlikely that HDL is a causal risk factor. And this is what they're saying, not what I'm saying. Because the studies we have that might seem to prove, at least give us better evidence towards causation, don't show it. But with LDL, they do. So that's the primary working, it's a theory now that they're using. And it's come to my attention that people don't know the difference between a hypothesis and a theory. So a hypothesis is like the beginning of formulating a theory. A hypothesis is like, well, it seems like every time I eat carbs, I get fat. Okay, that's a hypothesis. A theory is an established idea that already has established evidence, a large body of evidence that suggests the hypothesis might be true. So the theory would be, if you eat more carbs, maybe you get fat. But metabolic ward studies show it doesn't matter whether it's carbs or fat. As long as calories are equated, it's the overall caloric excess that creates the body fat, and that's a theory because we have a large weight of evidence that suggests that hypothesis is true. Okay. Now I'm just saying. So so this LDL hypothesis, I suppose you can call it a theory. But no matter what something's called or how much weight of evidence something is, again, there's always questions to be asked. It's still up for discussion. Okay, So when we get like emotionally charged and we start name calling and stuff, or people just get like, they start talking absolutes. They're like, no, this is the facts, blah, blah, blah. You're blind, blah, blah, blah. That's a problem. That's not beneficial in regards to science and the academic study of such topics. Now, clinical practitioners need to have a degree of certainty in the things that they're teaching because their whole goal is to improve health outcomes and prevent people from dying. So if you're talking about heart disease risk or whatever, and you're potentially causing death upon people, that's a different kind of discussion than the academic discussion of health science and stuff like that. So for me, it's a unique position because I do work with the average population. I guess you can call me, I'm practicing, not practicing medicine by all means, but practicing health, fitness, nutrition, and helping people improve their blood markers through exercise and nutrition and stuff like that. But the academic study comes, and I'm more invested in the academic study. I've been studying the science behind all this forever. And that's different. Needs to be more questioning in the academic study. But in the clinical setting, you need to go based on the best evidence and give people practical guidance. Okay, so in summary, the idea that LDL is a causal risk factor for heart disease is largely based on studies done and observations on people who have genetically high LDL cholesterol tend to have more heart disease, pretty significant magnitude of effect. Whereas humans who have genetically low LDL cholesterol tend to have a significantly lowered risk or incidence of heart disease. And studies done on people who have heart disease risk, who have previous heart disease, who take statin drugs to lower their LDL, tend to have lower risk of heart disease risk. And there seems to be a dose-dependent response based on how high or low their LDL is, regardless of the intervention. And HDL cholesterol does not have this effect, okay? It is there's a pretty big correlation in the literature where free-living people, people who are free-living in the population who have a higher HDL, just like from their natural lifestyle, tend to have better outcomes for heart disease risk. But it doesn't seem to be a causal relationship, because when you try to when you try to increase someone's HDL if it's already low using drugs, or if it's a genetically high HDL, the risk for heart disease does not change. But when it comes to LDL cholesterol, changing the levels makes a huge difference according to this evidence. Furthermore, there are large meta-analysis of randomized controlled trials, and apparently evidence from for long-term studies on people which basically shows a dose-dependent relationship between LDL cholesterol and heart disease risk. So if you want to read more about all of this, okay, so I've talked about this before, and I've mentioned the study many times and discussed it before. Low-density lipoproteins cause atherosclerotic cardiovascular disease. One, evidence from genetic, epidemiologic, and clinical studies. A consensus statement from the European Atherosclerosis Society Consensus Panel. Okay, and this was the 2017 paper, but I believe they released a new one in 2020. So this is where that whole LDL as a causal risk factor comes from. And there are other studies too. There was a meta-analysis in 2018 that showed, LDL exposure over the lifespan, really, seems to increase risk. But yeah, so I'll link this study in the description. Now, again, let me put this out there. I personally am not saying that I believe in this. What I'm doing is just telling you guys where it comes from, and y'all can make your own decisions, okay? So again, there's probably lurking variables there. And also, keep in mind, pretty much all of this evidence is indeed funded by the statin drug companies. It actually is. If you look on all of the people who were involved in these studies and the consensus panel and the actual studies themselves, typically they have links to statin drug companies. But that does not mean that the evidence is just like useless or something, or it's tainted or something. That's just how things work, The best evidence usually requires a lot of money to fund. So it's like, obviously, drug companies are going to have enough money to fund the evidence. But, something else that I think is interesting is, don't you all think that if, this was driven purely by profits, they would find a way to show justification for medications to modify HDL levels too? Think about it. Because the average population of people who are at most risk for any disease, they don't care about their diet and stuff. So they're the ones who are going to take a drug to try to reverse their problem rather than lifestyle. And so, I think the drug companies, if they could fund studies that, show HDL as a causal risk factor in conjunction with LDL. Just like the Framingham data suggests. They suggest that LDL is important, but only if HDL and triglycerides are also out of whack. So, don't you think the drug companies would try to fund research that justifies making HDL drugs? That way they could make money by putting people on LDL drugs and statins, as well as HDL drugs and triglyceride drugs, to maximize profits. Why not just show, all of this is important, therefore we're going to make drugs for HDL too. But they don't do that. So just something to throw out there. But look, I want people to tell me in the comments what they think about this. And disagree with it, or whatever. Just talk to me, tell me what you think about this and what you think the case is, especially regarding HDL. And the motives behind funding research to justify HDL drugs. So, yeah, if you have any resources or further studies to link me to, go ahead and show it. I mean, I've found most of the prevailing research, but there's always something that I have yet to see. So, yep. Now, as far as what I believe, I'm not even going. I've already kind of talked about that in previous videos, but I think my understanding of all this is evolving, and also my stances on things will evolve as well. But yeah, so we'll talk more about this in the future. Leave a question, comments, disagreements, and whatever down below. Let's have a discussion.